right, good afternoon. Thank you for joining us for our Lunch and Learn series. We do want to let you know that this training is being recorded. Today we have Dr. Steve Goldberg. He is a psychiatrist that has been in the field and has worked with military and veterans and currently works with the Mental Health Association of Maryland. He also formerly served as a commissioner on the Governor's Commission for Suicide Prevention, and today he is going to talk to us about taking a universal precautions to reduce suicide risk approach for suicide prevention. So I'm going to turn it over to Dr. Goldberg.
Thank you very much. Good afternoon, everybody. I'm not sure who is listening on the other end, but I'll try to make sure my voice is loud enough so that people in the room can hear as well as those who are listening outside of here. And so today we're going to be talking about universal precautions, which is a topic that we typically think of in other settings. And hopefully by the end of this Lunch and Learn session, I'll make a case for why I believe this should be applied to suicide and the epidemic that is going around, that is present today, to reduce suicide risk. Because anyone could be at risk, and I think this is really the premise that I based my belief on universal precautions, this idea that there is no threshold or there is no group or there is no formula you could figure out to determine who's at risk. And when we look at universal precautions, there's an evolution of that concept, universal precautions. And so before we talk about suicide specifically, I think if we take a step back and think about universal precautions and what I'm assuming most people already just accept as universal, this idea about what we're going to do to reduce the risk of transmission of bloodborne pathogens. And it evolved during the AIDS epidemic, and I know that's not what we call it now, but at the time when this was coming up, that was how we all looked at it. It's an AIDS epidemic. We have to do something. And how are we going to prevent the transmission? And it occurs shortly after people started becoming aware that it was more than just a homosexual or IV drug abusing problem, that it was everyone's problem. So let's review a little bit about the AIDS epidemic. In 1981, it seems like yesterday, for those of us who were around and having to go through the anxiety of this, that the CDC published a report describing this rare lung infection, this PCP infection, that is 5 young, previously healthy gay men in Los Angeles. And this is probably the first real sign that the national attention was being placed to this potential problem, that they came to learn, as I said, not a gay or an IV drug abuser disease, but actually a disease that we all have to worry about. But after the affected population expanded to include any and all people. And then we started saying, well, okay, this is not as comfortable as we want it to be. It's okay if we know that if you're gay and we know that you're a drug abuser, then we don't have to worry about us, the quote normal people. And then very soon after, they realized that everybody's normal. In fact, everyone's exposed, and the transmission could happen in a lot of different ways. So a new approach had to evolve that includes a population-based approach, that we're not looking at specific at-risk groups, because the at-risk group is the population. And there were a couple of very poignant cases that really helped change the way that people viewed this epidemic. And there was a horrible situation with a dentist in Florida who actually purposely infected several of his patients that he chose specifically because of their demographics. One of them, a young college student named Kim Bergalis, who had since passed, was given it because he knew that she was virtuous and that had no reputation of being involved in drugs, or in fact they believed her to be a virgin. This was actually part of the whole case, and so purposely infected her to prove that it's not just a gay disease. He had transferred all of his holdings and all of his resources to his mother's name before any of this happened so that he could protect himself. So he infected a mother of several children who had been married for many years in a monogamous relationship, and again, purposely tried to draw attention to this. And when it came out, obviously the horror of what he had done, but the reality that, in fact, anyone could be at risk became very clear. And so you can't just tell who is at risk. And when I was a resident a few years ago, we were looking at violence and doing some of my research in that area. I had an attending who told me that if I just paid attention, I could know who was at risk and who I should walk to the back to do the evaluation and who I should stay up front with. And then at that point I said something like, oh, is that like HIV? I should know when to put gloves on and when not to put gloves. And so the next day when I was in front of the training director explaining myself to why I did that, he actually agreed with my belief, but not my delivery and the snarkiness in which I delivered it. And so I think that we came to this realization that you can't just look at somebody and know if they're at risk. In fact, it's silly. So what happened, we talked about these universal precautions. We're going to treat everybody as though they're at risk. And then this for the people who are in the room, does anybody remember when people did not wear gloves when they drew blood? We got 3 people raising their hands, myself included. And so there was a time when I was a medical student and learning to do this, that if I put gloves on for some people, they look at me like, I'm not dirty, you don't have to wear gloves. It was actually insulting to somebody to put on gloves to draw blood. You only did that when someone in the ER came in and had that look, and like, all right, well, maybe somebody could jump off on me, so I got to glove up. Okay, and so this idea that you can wear gloves for everybody, it took some time to go through and kind of this public awareness that everybody is at risk of infection, regardless of your lifestyle or your exposure. It could be medical illness, could be heterosexual contact. So it really took about probably 5 years roughly, which is not that much time when you look at public health and trying to changing perspective before we realized that. Because the CDC in 1989 released the guidelines to reduce the transmission. So 1981 was that first report of the 5 men with the pneumonia in San Francisco, and now it took almost 9 years later before we first came out with these types of guidelines. And during that intervening time is what had happened with all the public outcry and the cases that occurred to get people to really recognize the risk and what we had to do. But the solution was to treat everyone as potential risk and all bodily fluids as potentially infectious. I say this now, and it almost seems like, really, go work, I move on. We know this, but no one questions this in any way, shape, or form. And so this idea of this decision tree, and this is really the point I wanted to get to. In the universal precautions, the whole point was you want to avoid the decision tree. You don't want someone to have to make a decision, should I or shouldn't I? And that's really what made a tremendous change in public health and how we were able to reduce the transmission and really get a handle on it, was this idea that we're going to treat everyone as if they're at risk, and then we can look at it and do something about it. So we also had to remove the stigma associated with it. Wearing gloves. It's interesting, we're talking about stigma today. No one would ever put wearing gloves on the list of stigmas we have to deal with in 2019. But back in the 1980s, wearing gloves was pretty much telling people in a nonverbal way, you're dirty, and I'm worried about catching something from you. Now, again, we don't have that many people in the room. You can play along at home if you like, but how many people would allow someone to draw blood today if they were not wearing gloves? Someone comes up to you going, oh, I don't need gloves, you look clean. Well, I may look clean, but I don't know about you, right? You don't really know. And so it has become such a universally accepted practice that now the opposite is true. To not wear gloves, most people who have any awareness of infection and what could happen in the world and certain approaches say, no way, please put on gloves. If you don't have any, I'll wait. And so we got to get to this next kind of thought of where we are today with the definition from OSHA when they look at universal precautions. It's an approach to infection control to treat all human blood and certain human body fluids as if they were known to be infectious and other blood with HIV or hepatitis or other blood-borne pathogens. Think about that. So we're going to treat everything as if it's infectious first, and then we don't have to worry about what is and what isn't. Again, very common concept. I keep reiterating it to you because when I get to the next couple of slides and I start applying that same logic to the group that you're here to talk about today, hopefully it'll make just as much sense that we're thinking about it in that way. It is now universally accepted that we're going to use gloves. So now I'm going to use gloves to prevent the transmission of disease. So now let's talk about the suicide epidemic. Generally, in a lecture like this, I don't have to convince people that there actually is a problem with the rate of suicide and what we're dealing with. But just to go through it, this is from the American Psychological Association's webpage, and this is January of 2019, so we're not talking about years in the past. It's ongoing. There's an alarming rise in suicide in America. As you look back over the last 20 years, the rates have increased. And when you look at this, is a CDC report from 2018, June of 2018. A lot of you may have seen that, but if you look at the suicide rates across the U.S. in the last 18 years, and almost every state other than Nevada has shown an increase in suicide. And not to be flippant, but my assumption is that most of the people who get into trouble in Vegas go home and then take care of, again, not take care, it's a terrible way to say it, but then the reaction to their losses or the consequences of their decision may impact them. But it's just interesting that that is the case, and there's been no research that I'm aware of. I'm just wondering if some of it's the transient nature of the state. But when we look at all of the states around the country, the ones that have the largest increase, generally people assume it's the cities and the high population centers, but it's not. It's the center of the country, probably where there's less resources, where there's less to do, less opportunity to get connected to other people and to get some help and to get recognized. But when you look across the entire United States and you average it all out, we're talking about almost a 30% increase, 28% over the last 20 years. That's a tremendous increase, and I think we could talk a lot about the reasons, and I know Janelle has spent a lot of time trying to look at this and is working with the state of Maryland to try to impact this in a lot of different ways. But let's look at the numbers a little more, because again, I'm going to get to my point and try to point out what we're really looking at. But when you look at the suicide rates for males and females in 2016, one of the things that strikes me when I look at a chart like this is the differential. How many more men are dying by suicide than women? Okay, and this is not attempts, because a lot of the literature talks about there's a higher attempt rate on females than men, but in terms of the success rate, they talk about the reasons why, because of the lethality of the methods that they choose. You know, us men tend to be macho and think we're tough, and so we need a tough way to end ourselves, and so we do some very violent, very brutal things that have a higher risk of being seeing it to completion. And so these rates are high. When you look at the age groups, another one that people who don't look at this data very often are surprised is that it's the 65 and older group that is the highest rate. And if you break that down, you're really looking at even, you know, the men at that age, and we'll talk about race in a minute in terms of who's really looking at risk. And it tends to be the group that people worry the least about. Okay, old white guys, why would they be suicidal? They're rich, everything's good, they're fine, their life is fine, they don't have to deal with discrimination, they don't have all the stigmas associated with them. So we have all these preconceived ideas about who should be at risk. And a lot of times what we perceive to be as the at-risk population is at risk, but not necessarily the highest risk. And what I'm more concerned about and why I'm advocating for a universal precautions approach is that group of people that we don't think are at risk, those people who shouldn't be at risk, those people who, if I were them, I wouldn't want to hurt myself. And that risk, that decision tree that used to be applicable for a decision to wear gloves or not, right now is applicable to that decision of whether we're going to go forward with a suicide risk assessment, whether we're going to concern ourselves with some warning signs that if we were thinking about suicide, we would notice as warning signs, but if we were assuming that this person was not in that risk group, then maybe we assign a different meaning to those same behaviors. And now you can start seeing where I'm heading you, where I'm leading you to as we talk about this idea of universal precaution. So when we look at ethnicity in the United States, American Indian, Native Americans have the highest rate in terms of ethnicity, but the next group that is the highest is white non-Hispanic. So as I said, white old guys are at the highest risk of suicide, and my guess is if we took a survey of lay people, they would probably check that box on one of the lowest, unless they did some research or have something in the know. So when we look at now another population that's at risk, when we look at suicidality in general, So we say, okay, now we have some concerns. We know a little more that we have to worry about men. We might have to worry about old men. Now we know that we have the highest risk is for those who are white, non-Hispanic, other than, again, Native American. But it doesn't mean the others are zero. I mean, 10% is pretty high. So we're talking about every other group having at least a 10% rate in terms of making up the total. So to say, if I told you all that this weekend could be hot, you want to hear about it? We're all worried about heat. Everyone gets excited. All the news people are going crazy about how hot it's going to be. So you're going to go to the beach, because that's where we go when it's hot. And they told you, if you go to the beach this weekend, there's a 10% risk of rain. Who's changing their plans? We have one person in the room raising their hand, one pessimist in the room who says 10% enough. The rest, and I think, again, the personal preference, but most people would say 10% risk of rain. I'm not changing my plans. I'm not canceling my room. I'm fighting the traffic, and I'm going to go to the beach. However, you say, if I told you that if every time you turned on the light switch when you walked in a room, you had a 1 in 10 chance of being electrocuted, you probably would walk around in the dark a lot more often. And so when we look at this 10%, sometimes we have this tendency, again, to think, well, that's not the group we're worried about. We're worried about the big groups. We're going to focus on the large populations. We want to impact the rate of suicide in the best way possible with limited resources, so we're going to target those populations that are at the highest risk. Makes sense. That's what we're doing right now. That's our suicide prevention strategy that we look at. So when you look at suicidality in general, and you start talking about, well, what does that mean, suicide? I mean, well, I've heard people talk about being suicidal, and people talk about, well, thinking about it is different than having a plan, and having a plan is different than acting on it. But really, how many people are we talking about when we look at these numbers? Are we talking about a couple of hundred people somewhere that we have to try to find the proverbial needle in the haystack? Unfortunately, that's not the case. Because we look about almost 10 million adults, 9.8 million adults, this is from data from SAMHSA, that looks at, had serious thoughts of committing suicide. Okay, that's almost 10 million adults. So you can imagine how many people did not admit to it, or how many people had thoughts that were not reached whatever level of serious they defined. And then of that 9.8 million, 2.8 million made plans. And of the people who tried to die by suicide that made an attempt, almost 300,000 made no plans and just attempted. So, all right, we got to think about this. So if we try to deal with everybody who had suicide thoughts, say, well, really, of all the people who had suicidal thoughts, only 2.8 million, almost 25% of them, well, 30% of them, actually made a plan. And then we talked about 1 million actually made a plan and attempted. So that's 10%, 1 million of that 10 million. So we look at that. Someone says, I'm suicidal. I'm having serious thoughts of hurting myself. We respond to that. We say that's really a 1 in 10 risk of that person actually following through and getting so despondent and feeling like there's no other options if they get to that. But we also know there's this group who made an attempt, who made no plan. So we know there's going to be some impulsivity and some people who are going to react to their situations, who are going to have I'm feeling bad, I'm not really thinking about doing it, I'm making no plans, but something happens, and then they have an impulsive reaction. Maybe alcohol or drugs are involved. Maybe, again, it's just the heat of the moment type of thing. But we realize that we're dealing with a whole bunch of people. And so now when we look at suicide prevention, what are we talking about? Okay, we're talking about the same thing I've been doing for many years, and people have devoted their lives to it. I'm assuming most people in here today and who are listening care about this, so I'm not trying to talk about it in a negative way. So I want to start by saying that because it's what we do. But I'm also going to advocate and push a little hard for why I think this is an outdated approach and why if we do everything right with this strategy, we're still going to miss more than half of those people who die by suicide. And in my opinion, if you have a strategy where if you do it 100% correctly, you still miss more than half, you need a strategy. Okay, and so that's where I'm advocating for now. So the first point, as I made before, it's predicated on identifying high-risk populations. So let's try to have this greatest impact we can. Let's find out who's suicidal, because we know they're going to have a much higher risk. Let's look at the demographic data over time to see which groups we should be kind of trying to do outreach to try to penetrate their culture and try to get them to realize there's resources and things that could be done. And when you look at who those people are, and I'll ask in the room, just to kind of make my point, what are high-risk populations? Just start calling out what you consider a high-risk suicide population. Men, I told you that. That's
I mean,
no, I understand.
Okay, you want to go deeper than that?
Yeah.
How about women that domestic violence, human trafficking, and sex trafficking?
Absolutely. So people who, and I'll even go further, make it more general, people who suffer from trauma, okay, and including that as well. So absolutely. What other high-risk populations do we have?
Bipolar.
Bipolar, mental illness, right? And then usually substance use disorders kind of get thrown in there, another high risk. What about people who previously tried suicide? Right? We know that actually the highest risk. A previous attempt puts you right at top of risk of trying again. What about veterans? We know that has been a huge focus of attention on the rate of suicide with our nation's vets and coming down, especially over the last few years with the length of deployments and the exposures to so much. So we know, and when we start going through the list, we know that American Indians and Alaskan Natives are the highest risk, and a lot of alcoholism and others will certainly contribute to that and have confounding factors. But bereaved by suicide, so people who have been near someone or close to someone who died by suicide. Justice and welfare child settings. I worked in the correctional system for over 20 years. That was one of the highest risk populations. I used to have to tell the officers when I would train them that the moment they walk in the door, they're at risk. So you're looking for some other reason to make them find them at risk. They've already crossed that threshold of a higher risk than the general population by definition. What about those who are engaged in non-suicidal self-injury? As I said, those who hurt themselves are at a higher risk. Who have attempted suicide before, who actually not just self-harm, because we know people, there's a difference for those of us who focus on this topic a lot, that those who engage in self-injurious behavior without an intent to die versus those who are trying to end their life by suicide are different, but they cross over, and that line is a lot grayer than we once thought. What about medical conditions? Chronic pain, horrible prognosis, untreatable illnesses, family histories of people who have passed by many, many different types of illnesses that they envision themselves going, oh, I can't imagine getting to that point, or I'll never let myself get to that point, or if I ever got this, I would, type of thing. And you start thinking about how many of us fall into that category. Another whole group I just popped up that we've talked about, mental disorders, anyone with LGBTQ issues, the stigma they face have a much higher rate of suicide. We talked about veterans, men in midlife. So I will ask the question, okay, who is not included in that list? When you start going through the list of everybody you know, and let's go back through this again, because, again, I'm not trying to be flip about it, but I'd like to start someone to challenge you. I'd like to challenge somebody to tell me who doesn't fit into this list, okay? In terms of, now, trauma was supposed to be listed there. I don't know that it was added, but we had talked about it. I would add trauma and all of the different variables that can contribute to that experience. But who's not on this list?
Juvenile and adolescent.
Okay, infant, thank you.
Starbucks barista that was about 20 years old.
Okay.
Just quite started college, isn't in the military, and hasn't had trauma, mental health, or any of the rest.
So we have one. So what about the other people in America? We have one. We have a by Starbucks. We have a few baristas that might fit that category. But it's really when you start thinking about it. And this is when I was really presenting this first to the Commission on Suicide and Prevention. It really started occurring to me that why are we trying to figure out who's at risk? Because who's not on the list is the first question. The second question, the answer is less people than are on it. Okay, I challenge you to find anyone who's not on it. We found one category. But the reality is much more people are on it than aren't. We all know that. The second thing is, how do you know if the person you're speaking to is actually on the list or wants you to know that they're on the list? So now we have another problem. So I could ask you, are you a vet? I don't like to talk about it. Every time I do, someone says, thank you for my service. I don't feel like I should be thanked. I lost 5 of my best friends, and I should have been me. I'm not saying anything, so you don't even know that I'm a vet. Okay? What is your sexual preference? I don't know who you are. I don't know what you're thinking and what you're carrying of baggage, if I'm going to get the treatment I need, if you're going to write in my chart something. So, no, I'm not going to tell you that. It's none of your business. And so you start going through all of the list. You know, someone asks me if I'm an old white guy. I go, I'm not that old. You know? And so, you know, we really know that we don't know who's on the list. People aren't walking around with signs and with a set of letters on their forehead to tell you which one of those categories they're at risk for. So how do you know? So if you're waiting to find someone on that list, if you're looking for someone to pay your attention to, then you're probably missing many who are walking right by you that you're not attributing things to, that if your surveillance was higher or more attuned, then maybe you see things, or maybe you hear them say things that they're trying to tell you, but you're not listening to and putting them in a different category. And so this is what matters to me, is that how do we know who's not on the list and who's not on the list, and how do you know if they actually are, even if they are? Okay, you don't. So we need a new approach. And the approach that I think that we have to look at, and we really start thinking about the unique opportunities for intervention, because after all, any approach has to have some hope of success greater than the prior approach. Otherwise, what's the point? And we're going to be looking at people, several things, is that people considering suicide usually do seek help. When you look at the number of people who had seen their doctor in the 30 days prior to an attempt or death by suicide, the number, it will astound you. When you get to older adults, it's almost all of them. All right? And so we're missing something. Okay, they may not be walking in saying, hey, I'm suicidal, I'm feeling bad. Maybe they're saying, I can't take this pain anymore. Okay? Maybe they're saying, I don't know if I can handle another loss. Maybe they're saying, yeah, I got to deal with my allergies and stuff, but I don't know if I can afford that anymore after what has happened with my housing. Oh, housing, I'm a doctor, I don't worry about housing, let's just talk about your pills. Any side effects? No, good, next. Okay, and so that's kind of unless someone came in and you knew, oh, they're at high risk for suicide, and someone starts talking about that, then you go, oh, I better worry about this because maybe this is something I should think about. Maybe I should connect them to somebody. Maybe I don't want the last note in their chart, mine, and ignoring these things that could be perceived as warning signs, because now I know that I should be looking for these things. And so mental health professionals are not always in the best position to help. Okay? I do a lot of teaching with the workforce who work with older adults, and part of what we do is try to get them to see their perspective. Okay? And so if I ask you, how was mental health thought about in the 1950s? My guess is most of you wouldn't think it's the same as today. If you ask what happened to family members who were chronically and persistently mentally ill in the 50s?
They didn't have the same diagnosis way back then.
No, they didn't. What do we do with them?
Institutionalized, yeah.
Sorry?
They're institutionalized.
Institutionalized, hidden in the basement. Do you talk about it and go, hey, I'm sad today because my brother is, trying to beat up my mother again, and we had to there was no medicine to help, and so we're all going kind of not. No, we keep that private. Okay, and guess what psychiatrists did? Bad things. And so in the 70s, there was this movie called One Flew Over the Cuckoo's Nest, even, okay, where they had Nurse Ratched. You probably have heard that name, even know where it came from. Okay, Nurse Ratched was this evil nurse that was from the States. She was supposed to be the good guys, and she was going against Jack Nicholson, who was supposed to be the bad guys, and in the end, Nicholson didn't seem so bad, and the nurse seemed kind of worse. And guess what? The entire nation started assuming that stigma about mental illness, that mental health professionals are bad, are going to hurt you, are going to give you drugs, or they give you horrible side effects. They're going to put you away. They're going to take you away. People are going to know you're ill, and they're not going to want anything to do with you. And so we're now telling these people, how are you feeling? I usually go see the mental health professional. We have a psychiatrist available. Yeah, right. Keep them away from me. Okay? So we have to really start re-examining how we talk about these things. And even though we have a generation of people who, hopefully, and it seems that way, are more open to treatment and more willing to accept this idea that we're a big bag of chemicals held up by some bones, and there's really no difference between a chemical imbalance that causes diabetes or a chemical imbalance that causes a depression or schizophrenia. It's just this where in the body this chemical imbalance occurs. But that's not everybody. That's not the people who are at the highest risk necessarily. And so we have to think about that. And the other thing is that, this seems kind of silly, but life happens all the time. All right, so things just, you don't just put it on pause and say, okay, this is a problem, now let's just move on and we'll forget about this problem. What you see today could change tomorrow. What someone promises you tonight may not be a lie. Maybe they really do want a contract for safety to tell you they're going to be fine and that they'll call you if there's a problem or they'll do something. But the next time that happens, now their mindset has changed and they're not thinking the way they were thinking when they made those promises. And so it's really a very different, it's like a schizophrenic promising not to hear a voice. They don't want to, they're going to try not to, but sometimes the illness takes over and creates a symptom that they can't necessarily manage. So for all of these things, we have these unique opportunities, as I call them, for intervention to do something about. Because 64% of people who attempt suicide visit a doctor in the month before, okay? 38% in the week before. That's a whole bunch of people seeing a whole bunch of professionals that we're missing. Mental health professionals, according to CDC, more than half the people who died by suicide did not have a known mental health condition. I'm going to let that one float out there for a minute. More than half of the people who died by suicide did not have a known mental health condition. That tells me what I started with the premise earlier, that if we do everything right and we stop every suicide for everyone that we identified as having a mental health condition, we've prevented less than half. That's a strategy that is doomed to underperform. It saves lives, okay? Believe me, what we're doing now compared to what we were doing 10 years ago is doing a lot of good. Again, I didn't want to end this lecture or get it towards the end and people thinking that I'm putting down what we've done. What I'm saying is that we could do more, and that the way we're looking at it is a very narrow approach, and that we could expand our approach and just like universal precautions to have a tremendous impact on the transmission of bloodborne pathogens and other infectious diseases. We can have that same relative impact on suicide if we start thinking about it in a universal way. And so also looking at the same study by the CDC, the issues most frequently associated with suicide: strained relationships, life stressors, work or finances, substance use, physical health conditions, and recent and impending crises. Things that people don't usually see a mental health professional for. But they're seeing somebody. So if you think so, this is Dr. Mortier from the CDC, and I love this quote, because if you think of suicide as just like you do as other leading causes of death, like AIDS and cancer, with the public health approach, mortality rates decline, period. Well, we know that the same approach can work with suicide. So if we're going to talk about it, we already know that a public health approach, treating everybody at risk and looking at from top to bottom instead of trying to identify at-risk groups, has already proven effective in a lot of situations. Why can't we apply that to suicide? And that's my argument that we have. So let's look at universal precautions as an approach to reduce the risk of suicide. And when I say that, people are like, what do you mean, Mike? How is that different? What are we looking at? Well, we first got to start looking at suicide prevention. And I know it's a lot more than what I'm about to tell you, but just in terms of broad strokes and generalities. It implies that you first must be aware of the potential for suicidality to increase surveillance and deploy resources. Limited, you have to know who to worry about, and you focus and target. We did that many times in the Suicide Commission, just talking about who are our high-risk groups, what can we do to target them, what organizations, what conferences are they having, what group, how can we show up in the middle of their thing and make sure they know resources are available. And that's what I'm talking about. Again, not bad, but we could do better. Public education. So we're going to target high-risk groups. We're going to go out there and do a media blitz, and we're going to let people know teen suicide. I think that was a very effective one over the last few years, and I remember people bringing it up and the concerns over 13 ways or 13 reasons, I believe, was in terms of the attention to teen suicide and how much we have to pay attention to that and worry about it. But guess what? If you're looking at that and you're not a teen, it's not me. If you're looking at that and you're not interacting with teens, or you don't treat teens, and you don't have them in your world, your professional world, that's them. You do that automatically. It's just whether you want to or not. It's just a natural human kind of tendency. If it's not me, it's them, and if it's them, I don't have to worry about it. I'd like to worry about it, but, I have other things. it's easier to assume someone is not at risk. Isn't it? I mean, we do this all the time in this idea that we're going to rely upon our professional judgment, and as a result of that professional judgment, when someone's at risk, we're going to do what we know is appropriate. And if I would argue to everyone in this room, as anyone who's ever worked in the middle of the night, who had just seen people throughout the day and have to work all the next day, and you have to make a decision, and if your decision is suicide and admission versus not suicidal and this person can come back tomorrow in the outpatient clinic, and your workload is the next hour is either sleep or filling out paperwork, you may have an unconscious drive to not want to see that person and say, well, I can see it, but it's not that bad. You know, and again, I'm not suggesting anyone is unethical or not trying to do their best. It's just human nature. When you're tired, you're exhausted, we don't always make choices that give us more work, even though we may not even be aware of it. And we don't want to think of people as being suicidal. If we see someone across the table that reminds us of us, you can't be suicidal because I'm not suicidal. How could you look at you wearing a nice shirt? Well, they're almost the same color. I got feet, you got pink. Yeah, there's no way if you could be suicidal because we're too close together. You even got a beard with some gray in it like I do. And so, therefore, you can't be. And so if you tell me something that resonates with me, I'm going to talk you out of it in my mind because I don't really want to see myself in that reflection. Okay? What about if I'm sitting across from someone who reminds me of my grandfather? Old white guy. Right? We just talked about the highest risk population. Well, if this guy is at risk, if I start thinking about everyone that comes across from my desk, it looks like Grandpa is at risk, and I got to worry about Grandpa more, and it's a lot easier to think of him as safe. And so I don't want to believe he's at risk because then he's at risk. And that's kind of this mental kind of acrobatics we do, and why, again, I argue that decision tree isn't as black and white as we like to think it is. It isn't just a matter of this fits in column A, this fits in column B. Because there's so many other things that play into it. And part of the reason why I think our approach is not as effective as it can be, because humans are humans. I'm pretty sure everyone in this room fits that bill. And so we're going to do things whether we're aware of it or not. So when you look at suicide risk reduction, just start with the two titles. And again, I keep on saying this, but I mean it. I don't mean to be flippant about it, but if I could prevent suicide, I probably wouldn't be sitting here talking to you today. I'd be talking from Maui with a little camera on me, with someone fanning me as my little drink with a little kind of umbrella is sitting right outside the camera's view. Okay, because suicide prevention is unattainable. That's like saying no one is going to die from cancer. No one will take you seriously if you start talking about that. No one's going to have a consequence of diabetes ever again. No, it doesn't happen. And so if we're going to accept suicide as a consequence of illness, then how can we possibly say that we're going to prevent all of them? We can't. And so I think personally that the way to look at it is suicide risk reduction. Everybody is at risk. How can that be? How could everybody be at risk? Well, because you know what? If I take the most successful person in this room and you start telling me how blessed you were with all the things, I would agree with you. And I can tell you that in about 5 minutes I come up with a list of such horrible things that would happen to you that if all of those things happen, you might consider it. Okay? And so if that's the case, if there's any scenario in which someone might consider it, then everyone's at risk. Because we're not sharing our playbook with people. We're not going out telling people, by the way, I'm in this category, I'm in that category, my marriage is at risk, I hate my job, my kids look at me like I'm a loser, and now you're telling me I'm going to lose a job, and I'm 65 years old and I can't get another job, and I don't have enough retirement because I never saved the right way. You know, you can start imagining this kind of vicious circle. Anyone can be at risk. Suicide risk is never zero. So years and years ago, it was recommended in emergency rooms that when people do assessments for suicide risk, that no one ever says no risk. You say low, medium, or high risk. All right, if they're high risk, you better put them somewhere to help them. If there's moderate risk, you better do something that mitigates the risk. And only in the low-risk situations can you say, come back tomorrow. Okay, and it kind of, very broad, again, I'm being general, but that no one has pushed someone in the ER to know 100% whether someone's at risk. As a forensic psychiatrist, I've testified in cases where suicide, someone died by suicide, and the hospital or the physicians were being sued as a result of that action that they should have prevented. Okay, and then after, and in certain cases, the doctors and the hospital have not been held responsible because when you really look at it, you can't prevent something you couldn't anticipate. And if you did everything that is prudent and reasonable to try to reduce the risk, it doesn't mean there's zero risk. And so when we look at reducing risk, now it starts making sense that we can apply that to everyone. If you're not suicidal, then you don't need suicide prevention. But if you are like everybody else, then why wouldn't you benefit from reducing your risk? Because if we accept it's not zero, then any reduction is beneficial no matter where you fall, whether you're at 10% or 90%. Any reduction is positive. It applies to everyone. There's no one in my office, there's no one in my chair, there's no one that I'm interacting with that I'm going to assume is zero. So now when I hear something, when I start getting information presented to me, maybe now I'm looking at it in a slightly different way. And so this evolution from suicide prevention to universal precautions and now to suicide, reducing suicide risk. And so this is where I'm at. So the Reno Conference is viewed as the beginning of the suicide prevention movement. Okay, in 1999, the Surgeon General had a call to action to prevent suicide, which actually identified suicide as a public health problem requiring attention. 1999, that's 20 years ago. It's almost silly to think that someone had to write a paper, okay, just to get people to recognize that suicide is a problem. Again, we look at our evolution over time. No one's assuming you're not wearing gloves when you're drawing blood. Everyone knows that suicide is a risk and it's something that we have to try to prevent. And we talked about the numbers and the exposures. And in 2001, we talked about SAMHSA, who we've all come to look at as kind of one of the leaders in kind of generating data and information and best practices, or at least in the past. We'll see what happens in the future. But this idea is the country's first program with the mission of effectively reaching and serving all persons at risk of suicide in the United States. They didn't see my slide, because then it would have been everybody. But again, this was a time in 2001 where targeting those people who were at risk was the prevention strategy. And it's been effective in a lot of ways. So what is next? And then I'll open it up for questions and discussion in the last few minutes. Well, in the timeline, I would tell you that in 2018, before my commission ended, I had a chance to present to the Suicide Commission about this very concept, about universal precautions. Janelle and I were talking beforehand. I might have a chance to go back and talk to them again because we have a bunch of new commissioners that are in there. And I believe that we should really make this an initiative throughout the state because every practitioner, every clinician, everyone who interacts with a patient at any level should be thinking about suicide as a potential because no one is at zero. And so 2019, this is it. This is the public introduction. You could say I was there that time when Goldberg started giving his spiel and talking about universal precautions and trying to get people in the state to take this on. I mean, I'm one person, I'm private practice, certainly willing to do what I can and serve in various capacities. But this has to be kind of a mantra that everybody takes on. You would never draw blood without gloves. How could you possibly see a person and not assess suicide risk? I don't care where you are or what you're doing. Okay? And just by the virtue of acknowledging that everyone is at risk, it'll start reducing the stigma. We don't have to wait 20 years for some great study to prove anything to us. We already know what can happen with universal precautions and how that shift can happen very rapidly. And so 20, question mark, when are we going to make this a requirement in Maryland and across the country? Someone has an argument against it, I'd love to hear it, but I think that we really do have to take that next step and look at everyone at risk, and especially in this day and age of social media and instant information and pressure from every corner, regardless of who you are. By virtue of having a belief, you have to defend it now. Used to be that people could have different beliefs and have a discussion. Now you're either good or bad based on your belief. And that's going to have a greater impact, and I believe is continuing to push people's stress to the edge, and this is not going to get better unless we find a better way to approach it. So thank you for your time, and I'll open it up for any questions.
In some ways, this is similar to, well, not similar, but to have good outcomes on stigma reduction. I was thinking about the comment that you made about, back in the day when they weren't wearing gloves, if they did wear gloves, it was really stigmatizing for people. In the same way, I could imagine if you're selectively screening people at risk for suicide, that could be potentially stigmatizing also. And I think not just from a provider perspective, but even on the flip side, there are people that might look at those groups that we deem as high risk and say, well, I'm not in any of those groups, so I don't have to ever worry about becoming suicidal, and I think that's a really slippery slope for people to go down.
Absolutely, absolutely. And when you look at people who share their stories, who have survived suicide, talk about how I never thought it would be me, and how this sequence of events, how people all around them, I never knew. I've unfortunately been involved in several what we call psychological autopsies, when someone dies by suicide, and looking back and trying to second guess ourselves and kind of try to be a Monday morning quarterback. And there are always things that people say, maybe that was, maybe we could have done anything about it, but now that we're looking at it, knowing what we know, maybe there's something we could learn from it. Yes, sir.
Well, I guess my thing is about the limited resources that we're all faced with. And this universal thing is like fishing with a wide net. You're going to catch everyone, so now you're going to spend a lot of time, weeding the non-suicidal ones out.
Yep.
I can give you an example. I had to do an assessment on a woman for postpartum depression. She was 93 years old.
I'm sorry, postpartum depression, she was 93? Was this made up? Because I didn't see the news of the 93-year-old who delivered?
She answered a question in the ER about, and I'm like, her daughter is 50 years old. I'm like, no one thought that, she's 93, her, postpartum depression, right, really? So I had to go and see this woman, and I was like, really?
So I know that is going to happen and will happen, but I would also say that, like anything else, once it becomes accepted, once it becomes common, that 93-year-old woman's going to next time, because she knows every time she goes in, someone's going to ask her.
No,
she goes, that was 65 years ago, honey, I'm fine. In my mind's eye, the public is going to learn, our professionals are going to learn, and the new students coming in will become more sophisticated because they're going to make those mistakes, and then they're going to be made fun of, because that's what I do. I'm not nice. I make fun of people. And then ultimately, then they will say, you know what, next time I'm going to actually not just ask the question, I'm going to look up and just see, wait a minute, maybe, have you been depressed lately? No, okay, we're good. And I think that, but again, the idea of asking means that I could tell you that there are many people, if you go around, I've spoken to people, why didn't you ask the question? It's right there. Well, I didn't think they were. I don't want to insult them. I don't want to make them feel bad. Again, the same exact analogy that Janelle made with the gloves. This idea that it's the practitioner's discomfort that projects to the person who's answering the question. You're not suicidal, are you? Okay, you wouldn't be in that group that would make me worry about myself, would you? I don't have to go call my grandfather after we're done because you're not suicidal, right? Those are the kinds of, we might not say it directly, but we're certainly transmitting the answers that we want.
Well, I think that situation could have also easily been averted if in the screening process a PHQ-9 was also administered, because that would tell you about her current depressive symptoms. So I know some primary care offices are now administering that, like in your paperwork before you go back to see the doctor, they're administering that to everyone who comes in. Now, granted, so that happened I was looking for a new primary care doctor, and they did that, and doing the work that I do, I wanted to see what their response would be.
So you answered.
On depression.
By the way, that's why why we get along so well.
We're troublemakers.
Exactly.
But the last question on the PH29 asked if you wish you were better off dead, and I said yes. And she never addressed it with me. She came in, she said, here's a list of counselors in the area, you should consider reaching out to one. You came up pretty high as depressed, and that was it. So, even though this is starting to happen, I think, in some areas in terms of mental health and merging the somatic health system, there also needs to be, like, proper follow-up and making sure that providers know what to do once they do get a positive.
Well, and I think they're going to, more and more, these offices are employing a mental health professional to be part of the staff so that they don't have to wait and pass on that to someone else the next day, and they can have an immediate assessment in terms of a value-added service for them. I think that when payers start requiring it, that would change a little bit because, the cash always dictates what's happening. But I would also say that if you notice, you probably don't even register it anymore, but once I started working on this concept and started paying attention, you go to a doctor's office, they advertise about universal precautions. They brag that they're using universal precautions. So how much different is that than saying, we assume everybody's at risk? Same kind of signs. We employ universal precautions to address, reduce suicide risk. If you have any of these answers, we already have something in place. And normalize it so that everybody is doing the same thing and they're seeing visually and they're interacting. Again, that doesn't happen on a turn of a switch, but the universal precautions, again, 5 years roughly, 5 to 10 years, complete turnaround. So I think that we could do the same thing. And I think we have an opportunity. We have people who are paying attention. Fortunately, we have a mindset in this country where our vets matter to us, and so we know that that could be a driver. There's a lot of money available to that. But again, a lot of vets don't go to the VA, and a lot of vets don't admit they're vets. So if we're going to really address that, we have to address it.
So I don't work in a highly acute, with a highly acute population. I do school-based mental health.
Mm-hmm.
So part of our process is when we do an intake, we have a risk assessment screen. So we have that kind of built in. So what would your recommendation be for reassessment? When someone's already in care, they're kind of getting treatment already. Nothing's no major triggers or anything.
Mm-hmm.
But
Well, I think that if we take away, if we start stepping back from it, I'm just thinking off the top of my head, so forgive me if I'm rambling a little bit, but this idea that we have a targeted population, and if something happens, if they're in treatment, we're going to do this, but we know that when young people look to suicide as a solution, it can be very impulsive. It can happen in waves, in terms of clusters, to say, and it can happen in reaction to certain key events that may not be registered to adults as key events. And so I would look at universal precautions as that every time there's finals, there's opportunity. You don't have to be singled out. You don't have to fail. You don't have to have an issue. Everyone gets it every time there's a high-risk situation. There's a suicide, I think we do better with that now. We talk about everyone gets counseling available. But it's different, because what I used to do, what we used to call, when someone would have an incident, a critical incident reviews, and we do them after every time. And so anytime there was an incident, whether it was a suicide attempt, a sexual suicide, or violence or something like that, everybody involved on the unit came afterwards and looked at it and reviewed it. And so we didn't choose which ones to do. So again, I would look at it, what we do now sometimes with the kids, we have to first find those kids who are struggling in this time. We'll make it available. You come to us if it's a problem, as opposed to everyone gets it every time. Why do we have to go through this again? Because it could change. Maybe last time it didn't bother you, and this time you happen to know the person. Or this time it was connected, or something else is happening at home, or you also failed the class. That didn't seem like a big deal, but now you think, so again, I think that when we start looking universally, I would look at notable events that are associated with it, and then rather than looking at the kids who are affected, assume they're all affected. And that way you don't have to raise your hand to be identified as being affected.
Also, in terms of reassessing someone that you've already assessed and has been getting care, the Columbia Suicide Severity Rating Scale, called the CSSRS, is available for free in the domain. They actually have a version for reassessing.
Yeah, that's built into our EMR, Columbia. someone has like active ideation, you're supposed to do a Columbia like in your next 3 encounters with them or you just keep doing it until they pop up with like a low risk.
Or until they figure out how to answer questions in a way that gets you to stop asking. Well, and I think that that's part of what we, again, I'm not putting it down, because I think you seem to be much more sophisticated in your approach than I've heard other places. So I'm not, again, putting it down. Instead, what I'm saying is that there are many reasons how people get around that. And one of them is I don't want to be part of it because everyone knows I am and they're not. So if everyone's getting gloves, it's universal. So I know we're out of time and people have to get back to their workday, but I'll stay after if anyone wants to continue to talk. But I guess we can officially get to that end.
Well, thank you, Dr. Goldberg. This was great.